So downregulation is the process by which a cell decreases the production and quantities of its cellular components, such as RNA, proteins, hormones, in response to an external stimulation. Okay. Can you hear me?
Yeah, we can hear you loud and clear.
Yes,
Okay.
Kundan. We
Okay.
can see your slides also. Go ahead.
Okay. So downregulation is nothing but you are reducing the function of the organ. So now when I say downregulation of pituitary gland, this pituitary gland is a kind of a boss of the reproductive system which releases certain hormones and it controls the ovarian function. It controls the process of reproduction. So now, if you look at the further steps of downregulation, let us understand that it is the process in which pituitary gland produces less pulsatile secretion of FSH and LH, which actually results into serum estradiol level less than 50 picogram per ml. Okay, so one of the very important criteria where we can say now the pituitary is down-regulated is by measuring the serum estrogen levels less than 50 picogram per ml. You can extend this threshold from 50 to 100, still it's going to be fine. Okay, now we know that pituitary downregulation is an definitely integral part of IVF before or during ovarian stimulation. Now I am very specific, before or during ovarian stimulation. So there are protocols where we actually achieve pituitary downregulation, before we start ovarian stimulation. Now the purpose in IVF is to prevent premature LH release before ovulation trigger. That's the whole purpose of doing a downregulation in IVF. Now, it's not that it is only used in IVF, it is also used in IUI, and we will understand in future slides that how it is very useful. So now this objective of pituitary downregulation is nothing but we have to understand that we need to prevent the LS surge or you may have to prevent the FSH release. So there are two objectives. Okay. So when we say any strategy which will downregulate pituitary, so ultimately pituitary is going to stop releasing FSH and LH both. But your purpose can be different. So for one particular situation, you want to prevent that LSS. That's why you are doing down regulation. In certain scenario, it will be like a preventing the FSH release, where we are not bothered whether LH is released or not. Okay. So these are the two important purposes of objectives of pituitary down regulation. Now, when it comes to strategies, what drugs we are going to use? So what are those agents which will help us to achieve the down regulation? So the ancient conventional agent is a GnRH agonist. We will understand the mechanism of action. Second is the GnRH antagonist. Then we can use agents like estradiol, oral contraceptive pills, and progesterone for the down regulation. Now let's go by one. So what is GnRH agonist? So we know that when it say agonist means it's going to stimulate the receptor. And what you mean by antagonist is going to inhibit the receptor. So there's a two difference between these two important molecules. So when we give GnRH agonist to the patient, it goes and gets attached because it is agonist. It will go and get attached to GnRH receptors. Now, GnRH is the hormone which is released by hypothalamus. So it comes from hypothalamus to the pituitary, and GnRH gets attached to GnRH receptors which are present on pituitary gland. So this agonist go and gets attached to and occupy those receptors, and it causes initial flare of effect because it is agonist. It is structurally similar to the GnRH hormone, which is our endogenous hormone. And that's why it stimulates the receptor. So because of which there is a release of FSH and LH from pituitary in first 48 hours after binding with GnRH receptors. See, we must understand that pituitary releases these hormones in a pulsatile manner. But when agonist is given, it's a continuous because agonist half-life is pretty prolonged. It's for 30 hours. And that is why it's just attached and it doesn't get a relief from receptor. So that's a continuous order which given to the pituitary, and that leads to continuous release of FSH and LH from the pituitary till it gets empty. So for example, consider one water tank and it contains 50 liters of water. So if agonist goes and orders this tank, the whole tank is going to empty the 50 liter of water. Now, to have a next water or next hormone level, you need a order from GnRH, which your endogenous GnRH cannot do anything because all receptors are occupied by GnRH agonist. And that's why now, after the pituitary is finished releasing the FSH-LH, now the pituitary gland is empty. Now there is no further hormone production and there is no GnRH order can act on pituitary. Now the pituitary is down regulated. Now it cannot release FSH-LH. So this is one thing which we need to understand. And that is why when you give agonist as a down regulating agent, if you need an endogenous LH search for ovulation trigger, you cannot use agonist again because already pituitary has got no LH, and that is why when you use GnRH agonist as a down regulating agent, you cannot use agonist as a trigger. You have to use SCG, which will directly act on the follicles. Okay. Now this complete down regulation. So when we start these injections on one particular day, it needs 8 to 10 days for complete down regulation. Okay. So that much time it needs to come. So what happens in the first 48 hours, as I said, there will be release of FSH and LH. So say imagine we are doing a long agonist protocol. I think we haven't discussed that, but probably by this time all of you know what is long GnRH agonist protocol. We start on day 21 or 10 to 11 days prior to the expected menses. We start GnRH agonist. So that is a luteal phase. So when we say I have started agonist, it is going to release FSH and LH. LH is going to go and stimulate ovary. It's going to produce more progesterone. So there will be more progesterone in the circulation. Understand? So after 2 days, there will be progesterone. That's why it takes some days to reduce those progesterone levels. And that is why it's normally around 8 to 10 days is required for complete down regulation. Now, after 8 days, the hormone levels start falling. That is, your progesterone levels start falling because there is no more endogenous corpus luteum is functioning. Okay, because it's already 28, 29, 30th day. So, and your further, LH is not coming from pituitary, and that's why patient gets withdrawal menses by day 11 or between day 11 to 14 any day. So if a patient comes to you on day 30, I mean, not day 30, 30-day cycle, you will start GnRH agonist from day 21. But if patient comes that she says that my cycle is of 28 days, remember you have to start on 18th or 19th day of the cycle. If patient cycles are even earlier, like date, say 26 days, you will start from 16th day of her menses GnRH agonist. So please remember 10 days are required for complete down regulation. Okay, so typically it is used for long GnRH agonist protocol, in which case it is started 10 days before expected menses. Now it can be used, same molecule can be used in a short and ultra short GnRH agonist protocol. What is short protocol? See, remember in long protocol, we are giving for 10 to 11 days before menses. Then we are going to start ovarian stimulation, and the duration of ovarian stimulation, we are going to continue agonist to continue its down regulating effect. So it becomes 20 to 22 days that patient is taking agonist injection daily. So that's why it is called long. When we say short, means this duration of 20-22 days, we are reducing to short. So in short protocol, we don't start it in luteal phase. We start it in the second day. We will understand that when I am going to show you the protocol slide. Now let us have, let's look at this particular, I'll go back 1 minute. Yes. Okay. So this is called GnRH long protocol. So patient who's got 30 days cycle on day 21, I'm going to start GnRH agonist as a 0.5 milligram daily. Now, a preparation which is commonly used is 4 milligram per 4 ml. Now, for luprolide, for buserelin, for all of this, we have these preparations available, 4 milligram per 4 ml. So we have to give 0.5 milligram per day. So 4 milligram per 4 ml is, when we calculate 1 milligram becomes per 1 ml. So 1 milligram per 1 ml. So when I say 0.5 milligram, I have to take 0.5 ml. So we know insulin syringe. 40 units marking is 1 ml. So we have to use 20 units of that syringe. That will be 0.5 milligram. So we can ask a patient to fill the syringe from the vial of 4 milligram per 4 ml up to 20 units, and that becomes 0.5 milligram.
झालं म्हणून सांगा.
Okay. So patient is going to take daily 0.5 milligram from day 21 till the patient reports that she got her menses. Most important, you are not going to ask her to stop the injection. So you have to inform this, because typically patients do these mistakes and they, as soon as they get menses, they stop it, and we want continuous effect of this down regulation. And that's why when you give instructions for on day 21, please inform her that you have to continue till I don't tell you to stop. So even if you get your menses, you're going to continue on first day. You have to visit to us on second day. You have to take that dose again on the second day and come to us, so that down regulation agent effect is maintained. So as I hope you see my marker. Otherwise, let's see. Okay, let me get some laser pointer. Okay. So can you see that it has started from day 21, patient got her menses. On second day, I have started her on gonadotropins, but I have continued her GnRH agonist, okay, continuously till the day of trigger. And that trigger in agonist has to be SCG. You cannot use GnRH agonist as a trigger in this patient. It has to be SCG. So on the day of SCG also, we will ask a patient to take GnRH agonist. Now, if you ask me, sir, what is the best time to give agonist as a down-regulating agent? What will be the time of the day? Best time is to give it in the morning. So generally, we ask the patient that every day morning between 7 to 9, you take this injection of 20 units and do not stop till we come to the day of SCG. And last day of SCG, when last day of stimulation where SCG is given, we give this agonist as a trigger. So this is called long agonist protocol. Now, what is short protocol, or it is also known as flare protocol? So what happens in this protocol, that you may have given OC pills, or you may not even given any OC pills. So it's not necessary that you have to give OC pills. Patient reports to you on second day. What you do, you ask a patient to take GnRH agonist, but this time instead of 0.5, you will ask her to take 1 milligram. Okay, so it's double dose. So 1 milligram she will take on the first day of stimulation, second day of stimulation, and third day of stimulation. So 3 days she will take 1 milligram per day. Of course, you have to start gonadotropins from second day of menses. That is, that is important, because we want endogenous FSH, which is released in quantity because of GnRH agonist. Here we are using that flare effect of agonist, which we have already discussed. So pituitary releases lots of FSH and LH, but here we are intention of using flare effect is to have more FSH from pituitary gland, and plus we are giving HMG or recombinant FSH from outside. So it helps us for a better recruitment of follicles. Then we know that after 4 days, because there won't be now any more endogenous FSH release because the gland is empty, we reduce that dose to 0.5 milligram again, just to maintain that down regulation, so that there is no LS surge. Now, this will continue till the day of trigger, that is SCG. So if you have understood, in a short protocol, overall, the duration of agonist required is maximum 8, 9, 10 days, not more than that. And that's why it is named as short protocol. Okay. Next is a ultra short protocol. Now, ultra short protocol, again, what you are doing in ultra short means instead of 9, 10 days in short protocol, you are making it more smaller duration, and that is the only first 3 days. So when patient reports to you in this protocol, we ask patient to report on the first day itself. On first day only, we ask her to start taking 1 milligram per day. So she takes 1 milligram on first, second, and third day. On third day or second day also, you can start with HMG or recombinant FSH, and 3 days later of GnRH agonist 1 milligram, you stop. You don't give agonist, and you only continue gonadotropins. Okay, so we have again utilized same effect of flare effect, where we have lot of FSH endogenously, and exogenously our gonadotropin dose selects good number of follicles. We allow them to grow, and because the pituitary is blocked or empty, Now we stop agonist because we know that the gland is empty. Immediately within say next 2-3 days, there won't be any LH surge or premature LH surge. So what happens? We start monitoring with the follicles. Now when the follicle become more than 14 millimeter, means 14 or more than 14, then in this ultra short protocol, you add a GnRH antagonist 0.25 milligram. So in ultra short protocol, you are using not only one, but actually two agents, which will downregulate the pituitary. And you will continue antagonist till the day of trigger. So generally, these protocols aimed to enhance ovarian response by enhancing the release of early follicular phase FSH. So because we are giving in first 3 days, so we want that early follicular phase FSH release with no profound inhibition of ovarian response through the ovarian GnRH receptors while sufficiently inhibiting premature LH surges. So this is what is called ultra short protocol. Okay. If you ask me, sir, what is best protocol, we'll definitely understand. This is one of the meta-analysis in 2014, and sorry, this was a randomized control trial in 2014. 111 patients underwent different protocol. One group underwent long GnRH agonist, one group underwent short GnRH agonist, third underwent GnRH antagonist protocol. When they found that number of oocytes retrieved in all these protocols in this patient, they realized the significantly more numbers were in long agonist protocol. And that is why, and when long was compared with short agonist, there was a significant difference, almost double. That if you use long agonist, you have a better number of oocytes rather than using a short. And that's why short agonist protocol was not so popular. Okay. And when we see compared the ongoing pregnancy rate, agonist versus means long versus short agonist, it was same. So what it just tells us that probably we can use long agonist usually because it gives us more number of oocytes. Probably using that protocol, there is no harm on ongoing pregnancy. It is same in both protocols. And that's why we commonly use long GnRH agonist protocol. Now, if you look at the ongoing pregnancy rate, as you see it in this table, look at this GnRH antagonist, which is around 16.2% ongoing pregnancy rate. Means even antagonist protocols are better than any long or short agonist protocol because you have a better ongoing pregnancy rate and there is not much significant difference between agonist long versus antagonist, as you can see 4.42 versus 3.30. Right. So now, if you look at this particular, study in 2017, which is a systematic review and meta-analysis accounting for patient type. So in this review, antagonist was compared with long agonist protocol. So 50 studies were included. 34 studies were reported on general IVF patients. Out of 50, 10 studies were reported on PCO patients and 6 studies reported on poor responders. So you had both extreme category of ovarian responders and general IVF patients also. So what is good, agonist or antagonist? So in women with PCOS or in women with poor ovarian response, both extreme groups, there was no evidence of difference in ongoing pregnancy between antagonist and agonist group. So even for PCOS, in terms of outcomes, reproductive outcomes, probably both are good. Antagonist is also good and agonist is also good. But what they realize, significantly higher number of cumulus suicide complexes in antagonist multiple dose protocols as compared to GnRH agonist long protocol. So that was one intention. I know that one, that previous paper we saw that agonist gives us better number of complexes, but this is a systematic review of 50 studies and it says that no, antagonist gives us a significantly higher number of cumulus suicide complexes. And also in antagonist, you have a chance that you can use agonist as a trigger because you're in antagonist, though the GnRH gets attached to GnRH receptors and it antagonizes, acts as an antagonistic. So it inhibits the pituitary immediately to release. So there is an immediate effect. So there is no flare effect. It just blocks the pituitary for releasing the gonadotropins. There, when you use agonist trigger, this agonist trigger goes and displaces antagonist, and agonist itself goes and attaches to the receptors and causes flare effect, because of which we will get a LS surge And that is what is beneficial for us in PCOS patient, where we will be able to reduce the OHSS rate. So antagonist has been proven till now. So remember, when you are handling PCOS, when you are handling normal responders, when you are handling poor responders, PCOS is our first choice almost in all the category of patients. Now, what is the disadvantage which agonist has over antagonist, that I'm talking about disadvantage, is total dose of FSH was significantly higher. That was 1865 versus 1513 in antagonist protocol. So agonist, when you are using, you need more duration as well as more dose of gonadotropin. So of course your expenses are going to be higher when it comes to agonist as a trigger. Now, ultra-long GnRH agonist protocol for endometriosis and adenomyosis. Now, this again here, the whole purpose of using downregulation agent is to prevent estrogen, or reduce the estrogen levels in the blood circulation, so that the endometriosis and adenomyosis associated inflammation should reduce. So, ultra-long is called. Ultra-long means now we are going even beyond 20 to 22 days. So in endometriosis or adenomyosis, what you do is that on the second day of menses, you will give her GnRH agonist depot injection, or you can even start from day 21 of any cycle, but you give agonist first dose, and every after 28 days, she will receive another next two doses. So total three, and leuprolide depots or leuprolide depots or GnRH agonist depot injection, that is 3.75 milligram. You will give every 28 days for three injections. Once you give three injections, 10 to 12 days later, from the third dose, there won't be menses because patient is continuously on agonist injectables every 28 days. So there are no menses. So after the last dose, 12 days later, you will ask patient to visit, and you're going to directly start HMG or recombinant FSH for ovarian stimulation. Here, remember, because agonist depot is already in the circulation, which keeps on releasing agonist, and it keeps blocking the path receptor, there is never going to be any other agent required. So you are going to just give gonadotropins, maybe same steady dose or step up dose for 8, 9, 10 days till the follicles are 18, 19 millimeter. And then what you do is give a trigger. Again, being the most common disadvantage here again, if it is an agonist depot downregulation agent, you have only choice of trigger is SCG. You cannot use agonist trigger into agonist downregulation protocol. Please keep it in mind. Otherwise, typically mistakes happens into these cycles. Now, what evidence says about this protocol in endometriosis, that is ultra long, that is extended protocol of GnRH agonist prior to ART treatment, is to improve live birth rate is not recommended. So there was an era in between for 8 to 10 years where we used to prefer using this extended or ultra long protocol of agonist for all adenomyosis or endometriosis patient. Now 23 guidelines of endometriosis, they say that it is not recommended because we were uncertain about the benefit of live birth rate. No, it doesn't improve, and that is why since 23 guidelines came out of ISHRE, we have stopped using this ultra long or extended administration of GnRH agonist protocol. Okay, so there is insufficient evidence to recommend prolonged administration of combined oral contraceptive pills or progestogens as a pre-treatment to ART to increase live birth rate. So also in guidelines says you cannot use contraceptive pills or progesterone. There is no need. A specific protocol for ART in women with endometriosis cannot be recommended. So you can offer either long agonist simple conventional protocol or antagonist protocol as the patient is ready to undergo. There is no difference in pregnancy or live birth rate in any of these protocols. So you can choose your protocol according to the ovarian reserve. When you expect that the reserve is low, you can go for agonist protocol. If the reserve is like a normal responders or hyper responder, go for antagonist protocol, because you get that option of using agonist as a trigger in antagonist protocol so that you can avoid OHSS. Now, GnRH antagonist, which is another molecule, against this molecular structure says that it antagonizes the receptor, means it stops receptor order immediately, and it causes immediate suppression of gonadotropins released from pituitary within, say, maximum 3-4 hours or 5 hours. It will act and it will completely block the production of FSH and LH. But here, compared to agonist, antagonists do not have a flare effect. So that is why when you give antagonist, the gland filled with hormones is going to be the same amount of hormones for till you are giving antagonist, and that is why when you give agonist, has flare effect. So there is a hormone FSH-LH in the gland, and because of flare effect, then because agonist trigger is given, pituitary will release LH, and we utilize that LH surge for the oocyte maturation. So in GnRH antagonist protocol, typically you are going to start on the second day of menses, your first injection of gonadotropins. You are going to ask a patient to take the injection for 4 days, and then fifth day you are going to call back the patient for sonography and to decide the need of antagonist. Now I said decide the need means you may start or you may not start. So yes, antagonist has got two protocols. One is called flexible protocol, means you are flexible, you are not fixed on the day, you are flexible according to the follicular size. So in one patient you might have started after 7 days of stimulation, but in another patient you must have started on after 9 days of stimulation. But it is not on the days, it is on the follicle size. So when follicle reaches 14 or more than 14 millimeter, that is the time we start antagonist in during ovarian stimulation. That's called flexible protocol. The second is the GnRH antagonist fixed protocol, where the GnRH antagonist started on the fixed day, that is day 5 or day 6 of stimulation, irrespective of the follicular side, and that is called fixed protocol. So on day 5 or day 6, you can start cetrorelix and continue giving till the day of SCG. Even on the day of SCG, if your antagonist, uh, time, I mean the time of injection, if it is crossing more than 24 hours from the last injection, you have to repeat the antagonist even on the day of SCG. So remember, so that is why, we need on an average 5 or 6 antagonists in fixed protocol, but in flexible protocol, you might just need for 3 days. So advantage of flexible protocol is that you need less number of antagonist number of injections. And also it has been seen that in a flexible protocol, the doses of gonadotropins required for complete follicular development is little lesser with flexible protocol. It is more with the fixed protocol. So yes, it has got some advantage, it has got some disadvantage. Now the disadvantage is that in flexible protocols, there will be certain number of patients, they might not be huge number, they might be just less than 2%, who even surge by fifth day of stimulation, and that is going to be missed if you don't check and you don't give antagonist. So surge has already happened. So sometimes if the surge has happened, even if you are planning for frozen embryo transfer, there will be some effect of luteinization of the oocytes, may if affect in certain cases oocyte quality. And that's why for me in my practice, I follow generally day 5 fixed protocol, but you have complete choice of yours. It's an individual preference, because this 2018 studies clearly says that it is you use flexible or you use fixed day protocol, they are all equally effective. Now, this meta-analysis on again in 2005 that compared fixed versus flexible protocol. So it clearly says that there was no statistically significant difference in pregnancy rate. You go for flexible or fixed GnRH antagonist protocol, and there was a statistically significant reduction in the amount of recombinant FSH required for the stimulation with the flexible protocol. That's a big advantage. Now, which are the suitable candidates for antagonist? For me, first choice for any IVF is antagonist, number one. Okay. But I might change my decision depending on previous experience of that patient or previous performance, sorry, the performance of that patient in a previous stimulated IVF cycle, will help me to decide whether I should go for antagonist or agonist. And that is why when you note down the patient's history, always note it down that when she has undergone IVF, what type of protocol was used, how many number of oocytes she received, how many oocytes were M2, how many embryos, I mean, how many oocytes fertilized, how many embryos vitrified, or how many blastocysts formed, all will help you for to plan a IVF cycle next time. If she has done well on antagonist, you will go ahead with antagonist. If she was like a poor responder with antagonist protocol, we can go for agonist protocol in next time. So please, depending on the previous history, then decide this. But patients undergoing first line controlled ovarian stimulation, you can use antagonist as a first choice, or patient who have not responded to other controlled ovarian stimulation regimens like those with GnRH agonists, which we just discussed, or patients with a poor prognosis, that is all low reso patients. Oocyte donors, antagonist is the only choice because agonist is going to be as a trigger and has an advantage of prevention of OHSS in oocyte donors. Patients who are at risk for ovarian stimulation syndrome, we know that in previous stimulation, she had given more than 20-25 oocytes and she was landed in OHSS. Please, in such patient, antagonist should be the first choice. Patients with PCO, again, the risk of OHSS is there. Patient taking oral contraceptives to regulate menstrual cycle, GnRH antagonist. So after discussion of two very important down-regulating agent, I'm going to focus mainly on another three molecules which are used for a different purpose. Like one is the estrogen. Okay. Now, estrogen pre-treatment before ovarian stimulation. So it is like a long agonist trigger, a long agonist protocol. We are using agonist first and then starting ovarian stimulation. Here also, we are starting estrogen, then we are starting ovarian stimulation. So what is the purpose here? Now understand E2 is estrogen. So endocrinology of estrogen is that whenever you give estrogen, means you are going to increase the circulatory level of estrogen. So every time estrogen increases in the circulation, estrogen is going to inhibit FSH and it is going to stimulate LH. So we utilize this concept and use estrogen as a pre-treatment during luteal phase, just like same. We start on day 20 of the menstrual cycle. So we give for 10 to 11 days prior to expected menses. So here we are using that endocrinological principle of estrogen that it inhibits FSH. So what we can do is that we give the patient estradiol tablet 4 milligram per day, that is 2 milligram twice a day, from day 20 until next cycle, day 1. Okay. And when it was compared with the patient group who served as a control who did not receive it. So what they realized on day 8, day 8 of stimulations, who has received, follicles were smaller and their size discrepancies, they attenuated in estrogen group compared with the control group. So typically those patients who behave like asynchronous follicular growth, this patient should be given estrogen. Now, even with estrogen administration, you have that situation was associated with more than or equal to 16 millimeter follicles, more mature oocytes, and more better embryos when you give estrogen. So, luteal estrogen administration reduces the pace of growth, improves the size homogeneity of antral follicles on day 8 of recombinant FSH treatment, and increases the number of follicles reaching maturation at once. So understand that if you are using antagonists as the first choice for most of the patients, it's a good idea to give estrogen for this patient because this will avoid asynchronous follicular growth, and typically asynchronous follicular growth will be seen in a normal responders and poor responders. So whenever you are treating such these two category patients, you must give estrogen before antagonist so that there will be a sequential and synchronized follicular growth, and antagonist can be added later for prevention of late follicular LS surge. Okay. So 2003 prospective randomized trial, okay, on 90 IVF embryo transfer patient, and they realized that when you give pre-treatment estradiol during previous luteal phase, the number of follicles are more in favor of estrogen supplementation. Number of mature follicles, they were significantly more, and they were in favor of luteal estrogen administration. And even the number of available embryos were significantly higher when you give luteal estrogen levels. So if you look at this particular concept, it's like in any normal responders and poor responder, your first choice is GnRH antagonist. Don't forget to start estrogen 10 days prior to your expected. And why should we give on day one? Remember, we must tell the patient that take estrogen tablet even on the first day of menses. She may not take on second day. Second day, she reports to center and you start gonadotropin stimulation, but ask her to take day one till day one estrogen. So, friends, I think there are lots of evidence which says that in especially poor responders, if you use this estrogen followed by antagonist, then your cycle cancellation rate reduces from 14 to 3% only. And even if you look at the excess embryo and rate of frozen embryo is 11% versus 2% in control group, means you get better number of embryos, so you can freeze them for the future use. Even in normal responders, the rate of frozen embryos were found to be 53% in when you give estrogen, and when you don't give, it was only 41%, again significantly in favor of giving pre-treatment. So these two category patients, you can start on day 20 or 21 estrogen supplementation, give it for at least 8 to 10 days. Ask her to continue till day one of menses. Day one, she will take estrogen. Day two, she will not take estrogen and report to the center. So this is how you can remember. Now, can we compare this estrogen with ancient downregulating agent, which is oral contraceptive pills? And they found that there was no significant difference when they compared these two molecules in mean number of mature oocytes, endometrial thickness, and embryo quality. The pregnancy rate in estrogen group was higher than the two other groups. Okay, so that is one group was oral contraceptive pills and one which did not receive anything. So comparing these groups, giving estrogen is better because pregnancy rate is better, but of course the difference was not statistically different. Okay, now going to oral contraceptive pills, which is the next molecule. Let us understand about oral contraceptive pills. Now, normally, again, the concept is similar that when you give oral contraceptive pills, there is a kind of estrogen progesterone in the circulation, and because of which the FSH is inhibited or suppressed, and maybe LH is also suppressed. So, uniform pituitary downregulation, what you get with oral contraceptive pills. So, either usually it is recommended that 12 to 16 days is sufficient enough to use oral contraceptive pills, and then once you stop OC pills, 5 days later, you have to start the stimulation. Okay. Now, this protocol is compared with long agonist protocol, which we have seen already, and they found absolutely comparable outcomes. So even using oral contraceptive pills rather than long protocol, you can have disadvantage because in this using OC pills, you have still advantage of using antagonist, and you will have lot of advantage of using dual trigger also. So in poor responders, this is very favorite that you give oral contraceptive pills and followed by antagonist and give a dual trigger because there are comparable effects. Now, also, this was a kind of a poster presentation in 2015, and they found that patients in the OC pills group also had higher estrogen levels on the day or on the day of SCG trigger compared to estrogen patch group. And there was no difference in the pregnancy outcomes after embryo transfer when comparing all three groups, that is oral contraceptive pills and estrogen and control group. So, only difference was that whenever you use oral contraceptive pills, you will need more gonadotropins doses and little slightly more duration of stimulation is required. Slightly expenses are going to be more. So what you can do is similarly that you start oral contraceptive pills maybe on the second day of the period, give for maybe 12, 16 days, even you can give it for 21 days and then stop. And after stopping, wait for 5 days because 4 days later you will not see any hormone levels, and then fifth day onwards you will start seeing FSH release getting released on fifth day after last dose of OC pills. That's why you have to start on fifth day after stopping oral contraceptive pills gonadotropins from outside. So ongoing pregnancy rate per randomized woman was significantly lower. See, this was a paper by Dr. Grisinger in 2010, and that's actually demotivated us from using oral contraceptive pills for IVF patients. He wrote that it was associated with a very low pregnancy rate, especially ongoing pregnancy rate when you are giving OC pills, before IVF. Even duration of stimulation and gonadotropin consumption is significantly more. Number of cumulus oocyte complexes, there was no statistical significant gain. But this recent 24 paper by Dr. Jun Gao in Human Reproduction Open, which was a randomized clinical trial. So they use oral contraceptive pills prior to ovarian stimulation for 21 days. Second group received directly ovarian stimulation without OC pills, and they found in parameters like number of good quality embryos, blastocyst rate, implantation rate, clinical pregnancy rate, live birth rate, cumulative live birth rate, there was no difference. So you can safely use oral contraceptive pills. There is no need to worry that using oral contraceptive pills reduces ongoing pregnancy rate. That was, overcome by this particular recent study. Next comes is a progesterone molecule. So we can use progesterone, and that is as a downregulation agent, and it is that protocol is called progesterone prime ovarian stimulation. So here, if you look at this particular concept, what it does is that if you have a high progesterone levels in the circulation, so that progesterone inhibits LH because of the because of the positive feedback system, negative feedback system. So when you start on the second day gonadotropins, on the same day you can start exogenous progesterone. So typically medroxyprogesterone acetate has been studied to be given in 10 milligram once in a day from the second day of the menses, or from the day we start gonadotropins as a stimulation agent, and continuously give progesterone in the same dose without any increment till the day of trigger. So even on the day of trigger, we will ask a patient to take tablet medroxyprogesterone acetate. Now, another molecule here you can use instead of MPA, and that is dydrogesterone. The only thing to have that similar effect, whenever you are using dydrogesterone, it has to be used 10 milligram twice a day. Like, unlike in MPA, it is 10 milligram once in a day, but in dydrogesterone, it is 20 milligram per day, and you will get the same effect of downregulation agent. So this was in 2024 meta-analysis and review when they wanted to know, is this progesterone prime ovarian stimulation is better in PCO patient than antagonist? So 8 papers were covered in this meta-analysis. 2,156 patients were involved in these 8 studies. Out of them, 1,085 patients received antagonist protocol and 1,071 patients in the received PPOS protocol. That is the protocol which we understood. Now, they concluded in this meta-analysis that PPOS group was correlated with a lower risk of ovarian hyperstimulation syndrome, but it requires more gonadotropins dose than antagonist group. But the OHS's risk is very, very low. And there was no difference into oocyte condition and the pregnancy outcomes. Like any clinical pregnancy rate, ongoing pregnancy rate, there was no difference. So without affecting the outcome, it reduces the OHS risk significantly, and that is why it was considered also equally better downregulation protocol for PCOS patient. Now, when it comes to frozen embryo transfer, pituitary downregulation in frozen embryo transfer cycles, what can we and where we can use? So typically, when you are preparing an endometrium for frozen embryo transfer, one of the protocol is the hormone replacement cycle protocol. So in HRT protocol, you can use GnRH agonist downregulation protocol. So here, what we do is, here again, the purpose here of giving GnRH agonist is to not to prevent LH surge. It is also to avoid or release or prevent the FSH release. So here, what we do is, on day 21, instead of that 4 milligram per 4 ml, we give GnRH agonist depot injection intramuscularly 3.75, because this depot keeps on releasing GnRH agonist, which keeps the receptor blocked for almost 28 to 30 days. It has been suggested that this effect of downregulation by depot preparations remains for 50 days almost. It's not only 20 days, it remains for 50 days. And that's why, as usual, we give it on day 21 so that after 10 days, patient gets her menses, and that getting menses itself is a confirmation that the pituitary is downregulated completely. And then second day onwards, we can start giving estradiol valerate or estradiol hemihydrate in doses of 4 to 6 milligram per day. And then we can keep increasing as per the response every third day or every fourth day till we get a desired endometrium where we can start progesterone. So now, the only advantage why downregulation helps in this, suppose your patient's endometrium mylu parameters are not good at the end of 16 days, you may need to give more estrogen and more duration of estrogen administration. Then you can safely do it in downregulated cycle because you have choice that depot is given. There won't be any FSH and LS surge in response to your higher estrogen levels. So you can buy some more days in downregulated cycle, or you can schedule it better according to your availability. That is just possible only with GnRH agonist downregulated cycle. Okay. Now, do we need to do this compulsorily in all PCO patients? That's the question. So this is randomized control trial, which compared that if HRT protocol given with downregulation with agonist compared with estradiol supplementation, that is HRT without downregulation. So do we need it compulsory in PCO patients? So there was no significant difference in clinical pregnancy rate, implantation rate, miscarriage rate, live birth rate, no difference at all. So it is not compulsory that all PCO patients should be subjected during FET cycle endometrial preparation protocol with HRT, which is downregulated. No, you can go for HRT protocol. But as I said, you have two good options. You can schedule the cycle better according to your availability, and you have a better results. Okay, equal results rather. Now coming to the one last part, which is pituitary downregulation in COH and IUI cycle. Yes, it is also necessary in these cycles. So what happens, especially the protocol where you are expecting more than two dominant follicles. So remember, endogenous premature LS surge, forget about premature, the endogenous LS surge happens when the estrogen level crosses threshold. Now this threshold is between 200 to 250. Okay, so if you have more number of follicles recruited in ovarian stimulation cycle for IUI, maybe 3 or 4, obviously the estrogen levels are going to go to this threshold earlier. So the more number of follicles, the more chances of premature LS surge, and we will have a failure of cycle, a failure of treatment cycle because of premature LS surge. To avoid this failure, probably those patients who's got multiple follicular growth, though it is under control, that is 3, 4 follicles, and you want to continue the cycle, you have to use antagonist as a down regulating agent because it will stop the premature LS surge in this patient. Okay, so even it can happen with gonadotropin. So typically when you use letrozole for 2 days and fourth day onwards you introduce gonadotropins, there you will get 3 to 4 follicles. Or in pure gonadotropin cycles where also with increasing doses you will get 3 or 4 follicles. So in those cycles, you need to control or prevent premature LH surge by using GnRH agonist. And this meta-analysis in 2014 says that if you use antagonists in IUI cycles, it significantly increases the clinical pregnancy rate and decrease the pregnancy loss rate also in IUI cycles. So how do we use this? So there are two ways you can use it. Once the follicle reaches, means follicles reaches 14 or 15 millimeter, then you can add without testing it. But if you can really test LH levels on this day, so you will be able to better decide that my patient does it really require. So what we do in our practice that whenever follicles reaches 14, 15 millimeter, we send the LH blood sample. By night 9:30, we do get all by emails, LH reports, and antagonist is given with the patient at home. So 9:30, they talk to us. If she needs to be taken this antagonist because the LH is beyond 5, so we will tell her and she will take it at 9:30 and she will continue this antagonist till the follicles are 18. So normally, when if we send LH in these cycles when patient is on gonadotropins, normally you see that 14 millimeter follicles will be ready on within 2 days to 18. So you need 2 or maximum 3 antagonists in IUI cycles. So friends, with this, the whole intention of designing this presentation was to make you understand that we can utilize pituitary downregulation concept for different scenario and utilize it to prevent the failures or to prevent complications. So success is no accident. It is a hard work, perseverance, learning, studying, sacrificing, and most of all, love of what you are doing or love of learning to do so. So remember, do what you like and keep fighting to get excellence in that field so that we become experts for our patients and deliver a maximum pregnancy rate. So thank you friends for patient hearing. If you have any questions, I'm happy to take those questions now. Thank you very much.
Wonderfully concluded, Kundan. What you said was perseverance and love for what you're doing, and I see that love in all the participants who have joined. And let's see what are the questions that are there in the chat box from Ranjana. A lot of information, wonderful, sir. That is the response you have got from
Thank
one
you.
of our members, Vandana. And there are some questions. Can you take them?
Yes, please.
Huh.
Okay. So that is in chat box, I think. Okay.
Yeah, yeah.
So
Chat box
let's,
question.
how much depot dose to be given? That's, I think, first question has come. How much depot dose to be given? Now, probably if you are asking for ultra long protocol, then at least 3 cycles you must give. So 3 injections of depot you can give. And if you are using like if you are asking me that for FET protocol down regulation in HRT, then only 1 dose is sufficient on day 21. But for ultra long, you at least should give for 3 more doses. Then dose E2, okay, dose E2 for what? Yeah, okay. If it is pre-treatment estrogen, in that perspective, if you are asking me, then the dose is 2 milligram dose of tablet twice a day. That is 4 milligram per day is the dose which is to be started from day 20 of the cycle and continue till day 1 of the menses, next menses. On second day, you're going to start ovarian stimulation. So that is the duration. How cetrolix comes in ampule or vial? No, it is nowadays cetrolix is available as a pre-filled syringe in a fixed dose, that is 0.25 microgram. Previously, it was available as a lyophilized, so in a powder form. So you have to mix that powder into solvent and prepare that injection. Then that was available in a ampule as well as vial format. But now majority of the manufacturers, they have cetrolix available in a pre-filled syringe. So it is just remove the cap of the needle, remove the air bubble, and patient can take subcutaneously cetrorelix. So on the thigh, on the abdomen, or the forearm. Now, question will be longer to type. Questions will be long to type. Okay. Other protocols for FET cycle than HRT. Okay. Now, typically, other protocols are, one is a natural cycle protocol. In natural cycle, there is no question of any down regulation because it is a single follicular growth. There is no pituitary, I mean, no multiple follicular growth. So less likely that premature LH surgery will happen. So you don't need. In modified natural cycle, the again it is similar like natural cycle. The only modification step is once the follicle is 18, you give SCG as a trigger. So you get a better, kind of progesterone support in early luteal phase. And the third protocol is a ovulation induction protocol, where again you are using more of a like letrozole because you want to just form a single follicle in anovulatory patient to produce endogenous estrogen for the endometrial development. So again, you are not expecting. Yes, if you are using gonadotropins as a ovulation induction drug, then you may have 2, 3 follicles. There you might think of, but you can always check with LH levels on when the follicles are 14 and then decide whether to use antagonist or not. Now, which protocol is better for normal responders? Now, if you ask me for any normal responders are little unpredictable because you may expect that she may give me between 8 to 15 oocytes is considered as normal responders, but they can respond to your stimulation protocol exorbitantly and you may get 20-22 follicles. So whenever, remember, the trigger is given on the last day of stimulation. So best thing is you use antagonist for all normal responders first of all, because you get that choice on the day of trigger that if the response is more, where I'm going to get more than 15 oocytes or the estrogen levels are more than 3000 on the last day, I can easily switch to agonist trigger on that day rather than giving a SCG, so that I prevent mild to moderate OHSS also in normal responders. So my suggestion is go for antagonist in normal responders and have that choice depending on follicular response which trigger to use. In which patient long agonist protocol is best? So remember, long agonist protocol is reserved for mainly now poor responder patient. Especially suppose on the second day when patient comes to you who is a poor responder or a poor reserve patient, and when you look at the sonography, so normally your antral follicle should be in the range of 3 to 7 millimeter uniformly. But sometimes we do see patients having those antral follicle on second day, instead of up to 7, they are 9 to 12 millimeter size. Now this patient will show asynchronous growth. So identify these patients on second day. Do not start stimulation or ovarian stimulation on this day. Call her on day 21 and give an agonist long protocol. And then once she gets up menses, then you start ovarian stimulation. So this way you can even identify who will land up in asynchronous, but by using long agonist in this patient, you have prevented that asynchronous follicular growth also. What E2 level correlates with OHSS? So I think 3000, remember, because any estrogen levels above 3000 patient will land up in moderate to severe OHSS. Below 3000 will be mild OHSS. So 3000 is the cutoff which is best followed. So you should select your lab which gives you accurate estrogen levels. For me, it's not in favor, but for me, it is in Pune, we have best hormonal results are with Metropolis lab. So, or AG diagnostic. So these labs are very consistently gives us, estrogen levels properly. So you need to find out in your own city which labs are better in this. And maybe after doing few tests only, you're gonna get to know that, okay, this lab is better. But 3000 is the lab estrogen levels you remember. So that was the last question in the chat.
No, I think Ranjana wants to ask you a question, but it seemed that question is too long to type. Ranjana, you
So
can
she
unmute yourself and
unmute
ask.
and talk.
Yes, sir. So my question is, like sir said, in FET cycles, when we are giving estradiol valerate, whenever we're starting on day 2 with 4 milligram or 6 milligram, and sir said that you increase after every 3 days.
That
On
is
the
in
fourth,
HRT.
yeah, HRT cycle, yes, sir.
Yeah. So you have two schools of thought. You have two types of evidence also in literature. One suggestion is that you give fixed dose, that is maybe 2 milligram 3 times a day, that is 6 milligram, continuously same dose for 15 to 16 days. Okay.
Hmm.
And another regime is where every after 72 hours, you increase the estrogen levels by 2 milligram. Okay. So if you have started with 6 milligram, fourth day, I will make it 8 milligram. Seventh day, I will make it 10 milligrams. So every 72 hours, I increase. Now here, the concept is same, that the estrogen not only controls endometrial growth, but it also regulates endometrial blood flow. Okay, so
Yeah.
sometimes with fixed dose, you may have a better endometrial growth, but you may not get a better endometrial blood flow. So
Okay.
if you keep increasing doses, your blood parameters, especially those subendometrial vessels, number of signals, PI, PSV in those vessels becomes much, much better. If you increase the dose, the PSV also increases. And increasing PSV is very important for your ongoing pregnancy rate and reducing the miscarriage rate. And that's why I prefer in favor, or I'm in favor of increasing doses of estrogen for those short duration. Even if it is short duration, you use that, you will have a better ongoing pregnancy rate.
Okay, thank you, sir. So one more question is, when we are like in IUI cycle, whenever we are like whenever you said we need to give an antagonist, when we predict that the LH surge is premature, so simultaneously should we again give a small dose of gonadotropin to prevent
Yes,
the
you have
follicle
to
from
give. See,
yeah.
when we are doing controlled ovarian hyperstimulation, I always prefer that you give daily gonadotropins. Okay,
Yes, yes.
need food for every day to live. Even the follicle needs everyday gonadotropins for their growth. So if you give every day, you can predict the follicular growth. So remember, with gonadotropins, the daily per day growth of the follicle is in the range of 1.5 to 2 millimeter per day. Okay,
Okay.
so you can better predict that, okay, today it is 14. I am sure with 2 days of gonadotropins, it is going to be 18. That kind of correct and predicted growth rate, you see it in with gonadotropin. So do not stop. In fact, when you give antagonists, you are in fact down regulating pituitary. So now pituitary is going to stop FSH from endogenous. So how follicle will grow? So you need to give gonadotropins from outside.
Okay. Sir, I was talking about IUI cycle.
I'm talking about IUI cycle only. So
Okay.
whenever you use antagonist in IUI cycle, see the antagonist within next 3 to 4 hours is going to block pituitary. So remember, if the pituitary is blocked, means pituitary is not only blocked for LH, it is blocked for FSH also. So now how follicle will grow? Your 14 millicle follicle to grow needs gonadotropins. Now the endogenous is blocked. So they are more dependent on your exogenous gonadotropins. So when you have to use antagonist, you have to give gonadotropins for next follicular growth for next 2 days.
Okay, sir. Okay, thank you.
I'm sure you got my answer.
Yeah, definitely, sir.
Okay.
Okay, sir. Thank you.
Welcome. Sir, sir, you are muted. Dilip sir, you are muted.
So now you can hear me?
Yeah.
Yeah. So if there is anyone who wants to ask a question,
I think there is one question in the chat box that can you
please.
give half of depot dose in HRT-FET for downregulation as it takes 50 days for it? So to be honest, I don't know whether reducing dose reduces the duration or no. That I don't know. Okay. Probably if you reduce the dose, probably you may not even able to maintain the downregulation effect for a longer time. That's what I feel. So right now, let's go by the literature. Literature says that if you use 3.75, you get consistent downregulation for at least 50 days. So let's stick to that. Let's not reduce the dose because saving half dose is not going to reduce the cost. That is very important. Okay.
Any more questions which can be taken? I mean, you can unmute yourself and ask the question. Are there any? No issues. You can always ask the question to Kundan on our WhatsApp group anytime you get into any trouble when you are stimulating your patients for your IVF and IUI cycles. So I think that should be it today.
Okay.
Yeah. Can you please share link of the WhatsApp group? Yeah, we will do that. We will do that.
Okay.
Yeah. So they will know where to post their questions whenever they have them. Right. So thank you very much for Kundan for a wonderful presentation. As usual, when you give your presentations, everybody is in your awe and they start asking so many questions. But maybe the questions will come as we go along and we go more into the depth of the subject as our journey goes towards more and more talks. So thank you very much for a wonderful talk and. Madhur has told you something that you can contact your question to him. He will post it to Kundan because otherwise Kundan will be hammered with so many questions for so many people all around. So you send it to Madhur and Madhur will edit and then pass it on to Kundan because I know Kundan is a very busy person. Let's not disturb him with posting questions on his WhatsApp number. So thank you very much, Kundan, for a fantastic talk. And until next Wednesday, let's all again come back on at 4:30 next Wednesday for another talk on this subject. So thank you very much.
Thank
Bye
you.
bye to all.
Bye.